Next, I have Dr. Amanda Dann. She's one of our awesome surgical oncologists here at UT Southwestern. She's also a physician scientist, so you'll see a trend here. So she was going to talk about surgery for melanoma and what to expect.
Thank you, Dr. Wang, for that introduction. Like he said, I'm one of our surgical oncologists here at UT Southwestern, and I specialize specifically in melanoma and other skin cancers from the surgical oncology perspective. But what you'll see kind of in the melanoma community in general and in the broader cancer community, we really like to think of ourselves as kind of a multidisciplinary group. So all the other speakers that you'll be hearing from today, I work intimately with as we make plans that are individualized for each patient. And I know that there are a lot of probably different stages of the melanoma trajectory of patients here in the audience. I want to first of all thank you for being here. It's really important for our patients to be staying educated and up to date. And we love, seeing you outside of the office as well. So when it comes to treatment options for melanoma, we're going to be talking about this throughout the course of the day today. And when we think about cancer treatment in general, often we kind of think of three broad categories. So there's surgery, which is what I'm going to be focusing on today. Radiation as another what we consider local or regional therapy. And then systemic therapies, which we'll talk about in much more detail. But these are kind of the medical therapies that can treat cancer throughout the body. So specifically for melanoma, surgery, I would say, is almost always part of the treatment plan. Radiation is something that we're using less and less as time goes on, as our other treatments get better. And then systemic therapy is used when needed, often for patients with a little more advanced than just the early melanomas. So when you're talking about your melanoma treatment plan, the first step is really going to be making the diagnosis. So Dr. Gill already spent some time talking to us about that, but these are often going to be things that are made, by the dermatologist in the clinic, even your primary care doctor, your surgical oncologist, if you happen to see one of them already. But like Dr. Gill said, you'd be amazed how many people come into our office and say, oh yeah, my wife pointed out this spot, or I was at the grocery store and a stranger behind me said, you should get that looked at. That's actually how a lot of people are getting these diagnoses made, especially in places that they can't check easily themselves or don't know to be doing these skin checks that Dr. Gill was just talking to you about. So when you have a kind of a suspicious spot, the next step is often going to be a biopsy. This will be done by your medical care provider, most frequently a dermatologist, but again, could be your primary care doctor. There's different kind of terminologies we have, different ways that these biopsies can technically be done. But these are usually in-office procedures. So something that your dermatologist will use a little bit of numbing medicine, take the biopsy, it gets sent off for the pathologist to review or the dermatologist to review under the microscope. And then that's when the diagnosis is made. So I actually just wanted to go through with you here an example of what a melanoma pathology report would look like. Because for a lot of patients now, when you get these results, they're actually coming to your patient portal online, sometimes before you actually get a chance to meet with your doctor and talk about the results. So just so you have a little bit of a roadmap here to what you'll see on a report like this and kind of the things you want to look at. So, they'll start with talking about how the biopsy was done, where it was done. But then the things you really want to focus on and the things that your physicians will be focusing on when they go through your biopsy report with you and kind of what to do next and what to expect. A lot of that is going to be based on what we call the Breslow thickness. That's actually the depth of the melanoma. So how deep does this melanoma go? That's really the primary factor that goes into kind of risk stratifying you and making the rest of your treatment plan is how thick that melanoma is. There'll also be other things that your physicians are going to think about, what the margins are on that biopsy. And then again, based almost purely on the depth is what's called your T stage or your T category. I know patients will often say, okay, doc, what stage am I? When it comes to staging melanoma, that kind of falls into different categories. The T stage is just based on how thick the melanoma is and some other features of the actual biopsy specimen or the melanoma specimen itself. Then we have the nodal staging, that's your N staging, and the M staging is related to whether or not it's spread anywhere else in the body. But usually when you're actually getting your melanoma diagnosis, the information you have is really based on that T stage. So just so you kind of know what you're looking at when you look at one of these reports. So let's say you've gotten the melanoma diagnosis, what comes next? As Dr. Gill said, this is, always a scary diagnosis, but we want you to all know that there are many teams of people out there to help guide you through this. And, for a lot of people, especially those with early melanoma, this is an incredibly treatable disease. So once you actually have that diagnosis, you'll be either, returned to your provider who made that diagnosis or be referred to a specialist. A lot of times that's a surgeon like myself, a dermatologist. Where we'll start is just by taking a look at kind of the whole body if that hasn't already been done. I will usually be evaluating where that biopsy was done, making sure it doesn't look like there's actually still some additional melanoma there, because that changes a little bit how I think about this. Like Dr. Gill said, we'll do a really thorough examination of your lymph nodes. If melanoma is to spread, usually the first place that it will go is lymph nodes. So your doctor will be providing sometimes a little bit of an up close and personal exam of areas where we know lymph nodes are frequent. And asking you some different questions about some potential symptoms you might have that might tee us off that this might be a little bit more of an advanced case of melanoma. But important to know, usually most people coming in with a melanoma diagnosis are not actually going to have any symptoms. In terms of other additional workup you might be expecting outside of the exam you get in the office, usually this actually isn't indicated, at least initially, for a lot of people coming in with their first melanoma diagnosis. So things like CT scans or PET scans, MRIs, specialty blood tests, usually for most patients, until we have more information knowing that it's indicated, a lot of that's actually not often the next step. So then what are the steps of treatment? Again, I know some of you have already been through some of these steps. Some of you have been through more advanced versions of some of these steps, but just to go through a little bit more what to expect, at least from the surgical perspective, which is often for most patients the first step in their treatment. So like I said, most patients are going to undergo surgery as part of their treatment, but what surgery do you actually need? So I'm going to talk in a little bit more detail about kind of different steps and different components of what might be your surgical care. So the first of which is what's called a wide local excision. Talk a little bit more about that. And then different options we have for surgical management of the lymph nodes. So wide local excision, what that means is we're going to be removing the melanoma or, the biopsy site with a rim of healthy tissue around it. So how much healthy tissue we remove is guided by how deep that melanoma was. Like I was telling you, that thickness really guides how we think about melanoma. So for something called melanoma in situ, which is what we consider a pre-cancer or a potential lesion that could turn into a melanoma, but we don't consider as an actual invasive cancer that can spread, we usually do a pretty narrow margin, just a couple millimeters. And then you can see there, as the melanomas get thicker, we usually end up doing a wider margin. So just to give you kind of a little schematic of what that means, if your melanoma or your biopsy site is there in the middle and you need a 1 centimeter margin around, the tissue that we should take out with the surgery is that bigger circle, the iris of the eye, if you will. But then in order to get these incisions to close nicely, we can't often just take out a circle because a circle doesn't close well. So we end up actually having to extend that into an ellipse, kind of rounding out the rest of the eye there. And so it closes in a nice straight line. So what that looks like in a real person is that was their melanoma lesion there. This isn't actually one of my patients, but a good example of what that looks like. And so the tissue that the surgeon will end up removing is actually that ellipse. So you end up with a larger incision than you might expect from where the spot is, but that's to actually get that skin to close nicely in a way that's going to come together to hopefully make as minimal of a scar or as minimal of an impressive scar as we can. So wide local excisions themselves tend to be usually same-day procedures. So this will be something where you come in either to the office or the operating room, but can often go home the same day. For most people, knock on wood, this tends to be a pretty low-pain procedure. Usually people don't require much more than Tylenol or ibuprofen after this. Like I showed with those pictures, I always tell my patients, and I actually draw out on for them what I plan to do, because you do need to expect probably a larger incision than you might think based on the size of your actual melanoma or the biopsy. And depending on where your melanoma is it might not be just as straightforward as we cut out a little ellipse of tissue and sew it together. Sometimes, especially on areas like the face or areas on joints or different parts of the arm, we can't always get that skin together in such an easy way. So sometimes this does require a more complex surgery where we actually kind of move tissue from one place to the other. Sometimes this requires things like a skin graft. And sometimes this can actually be a multi-step procedure instead of just that one-day surgery. The risks of the surgery for the primary melanoma tend to be the things that you might expect. You know, anytime we make an incision in the skin, you have a risk of infection. Usually, though, that tends to be quite low. Sometimes these incisions tend to be on a lot of tension because we had to remove a lot of tissue to get things together. So you can have issues with the wound separating or the wound not healing well. Bleeding or a hematoma forming under the skin. And then again, like I said, tends to be a longer incision than you think. Sometimes because we have to remove not only the skin, but the fat underneath it, you could have a little divot or something like that from where the area is removed. We have ways to address that. And then the possibility that you could have the surgery and then still have positive margins and potentially require additional treatment are always things I like to make sure my patients are aware of. The other part of the surgical management that a lot of people will undergo is what's called a sentinel lymph node biopsy. So the purpose of this part of the surgery is to assess whether or not melanoma has spread to the lymph nodes. For people that are candidates for a sentinel lymph node biopsy procedure, often this is done at the same time as the wide local excision of the first melanoma, if this is kind of all being diagnosed at the same time. And important to know, this is really a procedure that's to gain information that's going to guide the next steps in your treatment, rather than a surgery really specifically focused on removing a lymph node with cancer in it. So to just give you a little bit more information about how this procedure works. So your melanoma site, or the biopsy that resulted from diagnosing that melanoma, is going to be injected with a dye. There are different techniques to do this, different ways to do this, but most frequently, this is actually what we call a dual tracer, meaning you have two different dyes. So one is actually a radioactive dye that will be injected by specialty radiologists. Then that dye, you can see here, this is if you had a melanoma kind of on the flank or a melanoma on the leg. That dye then travels through your lymphatic chains and gets hung up in a lymph node. Most often that's 1 to 3 lymph nodes. In the operating room, the surgeon themselves will also usually use another dye. This is sometimes a blue dye, one that we can visually see with our eyes, something called ICG, which is a fluorescent dye, which we can identify with specialty cameras. But the goal is to have these dyes help us identify the lymph nodes that would be the most likely ones to have cancer cells spread there if they had spread. It's really important to know that if we identify lymph nodes that are blue or lighting up with this radioactive dye, does not mean that the cancer has spread there. It's just our way to identify the lymph nodes that would be most likely to have that happen, so we can be really targeted in the surgery to remove the lymph nodes. I also like to clarify with patients that we use the term biopsy, which I think is a little bit misleading as a name, because most people hear biopsy and they think, stick a little needle in it. But this is actually a surgical procedure where we need to make an incision and go in and fully remove the lymph node or lymph nodes that we identify with our dyes. Because what the pathologists are often looking for is actually just little microscopic spots of cancer within the lymph node. So you can imagine if you had a lymph node that's about the size of a bean and you stuck a little needle in it, you could easily miss a little spot of cancer. So we actually have to fully remove the lymph nodes so that they can be really thoroughly evaluated to know whether or not there's evidence that the cancer has spread there. Because again, that will affect kind of what we do next, and some of our other speakers will talk about. So in terms of what to expect with this part of the procedure, like I talked about with the wide local excisions, some bleeding, bruising, swelling, pain, infection. Anytime we make an incision, unfortunately, those are always a risk. But things a little more specific to this surgery, you can have what's called a seroma. This is one of the most common things that we see. Basically, it's a little bit of fluid accumulation where the lymph node was removed. Usually it's not dangerous. It will actually go away on its own, but occasionally we actually do have to drain this fluid if it's bothering you. The thing that we can also see is something called lymphedema. So what this is actually long-term or even permanent swelling. If this were, lymph nodes in the armpit, that could be in the arm. If it's lymph nodes in the groin, this could be in the leg. We have many ways to manage this, but it is one of the more annoying side effects, and sometimes can, actually be pretty life-affecting from this kind of procedure. Luckily, this is actually quite low, and I would say, the numbers we say are 2 to 10%, but knock on wood, I think it's actually in reality quite a bit lower than that. Depending on where these lymph nodes are, there are sometimes, especially in the armpit, nerves that run through that area that could theoretically be injured. Some people can have allergic reaction to these dyes that I was talking about. That's rare, but it can actually be quite severe allergic reaction. Again, we know how to treat that. We're familiar with how to treat that, but it can turn what's a pretty straightforward surgery into something that can be a little more complicated. And then this concept of a false negative, which means we take out a lymph node, there's no cancer there, and we say, okay, your lymph nodes are clean, but you might actually have a lymph node elsewhere that has cancer in it that wasn't picked up with the surgery. So the real question that, and I spend a lot of time in my clinic talking to patients about this, is who needs a sentinel lymph node biopsy? So for patients with that melanoma in situ, that pre-melanoma, or patients with really thin or low risk melanomas, we consider that less than 5% chance that it's spread to the lymph nodes, those patients generally we do not recommend a sentinel lymph node biopsy for. The thought is that the risks of the procedure are probably higher than the likelihood that we're actually going to get information that's going to change what we do. For patients that are more in that intermediate range, around that 1 millimeter mark, or a risk of spreading of about 5 to 10%, that's really a conversation you're going to have with your surgeon. So these are actually sometimes the longest conversations I have in the clinic of, whether or not we should do the sentinel lymph node. For a little bit higher risk melanomas, those thicker melanomas that have a 10% or more chance of spreading to the lymph nodes, we will generally recommend a sentinel lymph node biopsy in that case. Although just like with most things in medicine, this is always very nuanced. So depending on, risks for the individual patient or specific risk factors of their melanoma, we might be pushed one way or the other. And these numbers are not exactly strict guidelines. So one of the other surgeries I want to talk about, which luckily is becoming less frequent as we get better treatments for melanoma, is something called a therapeutic or completion lymphadenectomy or lymph node dissection. This is where instead of going in to remove just a few lymph nodes, we'll actually remove the entire lymph node packet or all the lymph nodes in a given area. Again, depending on where your melanoma is or where these lymph nodes are, that can be different places in the body. But the most common ones are what we call the axilla, which is the armpit, or the inguinal region, which are the lymph nodes in the groin. So, like I said, the details of what that surgery will actually entail depends a little bit on where those lymph nodes are. There are different techniques for how we approach these lymph node dissections. So that can mean through an open incision. We're more and more doing a lot of these lymph nodes dissections, what we call minimally invasively, meaning laparoscopically or robotically. For patients that have lymph nodes that are not just on the surface, but kind of deeper in the pelvis, which is where we will often see those, I will routinely do those surgeries robotically to try to minimize the incisions that patients have. Important things to know, and my hope is that this is pretty common knowledge, but for providers providing these surgeries, but I want to mention it because these are things that have changed pretty dramatically in the past 10 years. Having a positive sentinel lymph node, meaning when we do that procedure to remove a few lymph nodes and there is evidence of cancer in a lymph node. 10 years ago, we would then say, okay, you now need what's called the completion lymph node dissection, where we go in and remove all the lymph nodes. That's actually not the case anymore, and we recommend against that. So if you happen or someone finds themselves in that situation and someone says, okay, now you need a bigger surgery, it's just a time to potentially ask some questions, because the complications of that type of surgery are quite a bit higher than just the sentinel lymph node biopsy procedure. Particularly that lymphedema risk and wound complication risk goes from about 2% to up to 30 or more percent. So it is a bigger operation. We do still sometimes need to do it, and it is indicated, but luckily we're not having to do that as much as we used to. So I just want to end by talking about some other new advances in melanoma treatment that really affect how I practice as a surgeon. So we might touch on this a little bit later, but one thing that we're doing now, and this is actually a very recent change within the past year, one of the biggest advancements I would say we have in melanoma is the use of what we call neoadjuvant immunotherapy. What that means is using the immunotherapy actually before surgery in very specific contexts. So what we know is in patients who that's relevant for, and I'll talk to you a little bit more about what that means, we know that the risk of this potentially, of the melanoma coming back, can actually be cut in half if we do the immunotherapy before the surgery to remove the lymph nodes, compared to if we just use the immunotherapy after the surgery. So this really applies to patients that have more advanced melanoma, either at the time of their diagnosis or they have a recurrence of their melanoma, to the point where they have lymph nodes that are not just have microscopic little spots of cancer in them, but lymph nodes that we can either feel to be abnormal or, on PET scans or other imaging, we see that they are grossly abnormal and enlarged on the scans. I mentioned this to you all to be kind of our champions of promoting this information, because what we used to do for these patients was actually take them to surgery and remove those lymph nodes. And even now, after some of this information that says maybe that's not the best thing to do, we do still see that that's happening, because again, this is relatively new information. So if you or anyone you know is someone who falls into this category of, oh, I have a big abnormal lymph node, surgery should likely not necessarily be your next step. And I would recommend that what you seek out is actually a biopsy to confirm that is or is not melanoma, and then consult with a team who really thinks about this in a multidisciplinary way. Some of the other big advances we have in terms of surgical management of melanoma is really management of the complications of some of these surgeries. So one of those examples is more minimally invasive ways of doing those lymph nodes dissections, as I talked about. The way that we used to do it would be a big incision, let's say in the groin, that goes from basically the upper thigh to the lower abdomen. There are a lot of complications with those wounds healing, with just taking a long time to recover. Now that we can do these in more minimally invasive ways, the recovery time tends to be quicker. We also are getting much better at treating that complication of lymphedema. So UT Southwestern has a specialty program here for this, and many other institutions do as well, of actually offering surgical options to address lymphedema if you're a patient who that develops in. So like I said, lymphedema can be kind of a long-term complication of some of the surgical options we have for melanoma. But if you are a patient who falls into that category, I do recommend you seek out people who are actually specialists in lymphedema, because there might be ways to improve or completely reverse it. So in conclusion, when we think about surgery for melanoma, it is often a part of your treatment plan. So likely if you have a melanoma diagnosis, you will be meeting with a surgical oncologist. But in general, I just want to emphasize that often the surgery is not actually that scary. I want you to feel empowered to ask questions. So for a lot of this, like I said, it is often very nuanced based on a variety of different factors. There's not often always a right or a wrong answer for what should happen with you and your melanoma. So make sure that you're asking questions, that you feel comfortable with your treatment plan. And as a surgeon, my goal is really to provide the most effective and safest surgical treatment I can for you. But as a melanoma doctor and a surgeon scientist who studies melanoma, my real goal is that we get so good at preventing and treating melanoma that you barely need me. And I think, like I have said a couple times, where we have gone in surgical management of melanoma has been completely revolutionized, just in my time as a physician. So 10 or 15 years ago, Our routine wide local excision was 3, 4, even 5 centimeter margins, which is an area of skin about this big. And we were routinely doing these lymph node dissections in almost every patient with a, intermediate melanoma, thickness melanoma. And we have now, really been able to kind of walk back and what we call de-escalate our surgical care in a way that I think has really benefited our patients. And I expect that trend will continue. Thank you all for being here.